My name is Dominic Power. I'm a nerve surgeon from Birmingham in the UK. This is a presentation I gave to the British Association of Clinical Anatomists in December 2013. 100 years of nerve transfer surgery, the pioneering work of Adolf Stoffel. Now, motor nerve transfer surgery is currently popular in reconstruction of peripheral nerve injuries. It relies on the use of an undamaged nerve branch or a fascicle to transfer donor axons into a denervated distal target. And this is usually done close to the motor end plate, so there's a rapid reinnervation time, or it's useful when there's a distal reconstruction needed for a very proximal nerve lesion, which would otherwise result in no functional gain, or if a patient presents late after a brachial plexus injury or other failed primary nerve surgery. It's also an alternative when the bed is poor and not amenable to grafting. Now, nerve transfer surgery, as we currently understand it, in the modern era, stems from the work of Katani, Matsuda and Suzuki in the 1970s, describing spinal accessory transfer onto the suprascapular nerve through an anterior approach. They used the lateral branch of the spinal accessory nerve, so they didn't completely denervate trapezius, and they were able to bring through some neurological reinnervation to the supraspinatus and to a lesser degree to the infraspinatus. Nerve transfer surgery really became popular when Oberlin in Paris described in 1994 the use of a fascicle transfer from the ulnar nerve into the motor branch to biceps done in the upper medial arm. And this really changed the way we managed brachial plexus injuries in children and in adults by allowing rapid reinnervation of the important biceps muscle in patients who had upper brachial plexus C5-6 lesions with intact 7-8 and T1. Somsack Leechavengvongs spent some time in Paris with Christophe Oberlin and was concerned at the poor shoulder abduction function with the Suzuki transfer, and so he described an augmentation to this using a second reinnervation from C7 and 8 fascicles and branches into triceps through a posterior approach to reinnervate the anterior division of the axillary nerve, so the deltoid muscle and the supraspinatus both combined to give better restoration of shoulder abduction. This has been modified in Birmingham. We use the medial head of triceps frequently, which is a technique described by Susan McKinnon in the US. But we also use upper lateral cutaneous branch that would have otherwise wasted motor axons to the skin as a vascularized conduit with an anastomosis into the infraspinatus branch of the suprascapular nerve. And the reason we do this is we would like to augment shoulder external rotation. So not only do we get teres minor through reinnervation of the whole of the axillary nerve, but we also get some reinforcement of infraspinatus because the original Suzuki transfer done through the anterior approach often resulted in very poor reinnervation of infraspinatus. And I believe that one of the reasons for this is incontinuity lesions of the suprascapular nerve or multiple site continuity lesions of the suprascapular nerve, particularly injuries that can occur with traction and depression of the shoulder around the spinoglenoid notch at the base of the spine of the scapula. Now, as we gain experience in nerve transfer surgery, the indications are becoming extended and including lower limb reinnervation, and a paper by Shin and Spinner et al. From the Mayo Clinic talks about using FDL branches from the lesser toes through the interosseous membrane to reinnervate the tibialis anterior muscle through the deep branch of the peroneal nerve in continuity lesions of the peroneal nerve. And this is a technique we now use in Birmingham. I'd like to now talk about Adolf Stoffel. Stoffel was born in Germany, in Kaiserslautern, in 1880, and he studied medicine to become a doctor in Heidelberg, where he was supervised by Oskar Vulpius, a famous professor of orthopaedic surgery. Now, Stoffel's interest was in the anatomical distribution of central nervous system fibre tracts, and particularly he was interested in the descending tracts that were inhibitory on peripheral nerve function, and he developed an interest like that of his mentor Oskar Vulpius in the surgical management of spastic disorders. Eventually he was appointed in Mannheim as a specialist orthopaedic surgeon, but he continued to develop his interest in peripheral nerve anatomy, motor reinnervation and mapping the fascicles of peripheral nerves. For nerve surgery he developed instruments including nerve stimulated probes, and he began to define the branching motor anatomy to upper and lower limb muscles. What he's famous for is in 1911 he described in a paper a partial denervation for a quinovarus deformity in the lower limb due to spasticity, and these hemisections of motor nerve branches are still known as the Stoffel Operation and are used in select cases today for the management of severe spasticity. What is less commonly known is that he co-authored with his professor Oscar Vulpius a book entitled Orthopaedic Operations, and this was completed in 1911 but published in 1913 in Germany just before the outbreak of the First World War. Now, unfortunately, it was never translated into the English language, and because of the outbreak of the First World War, it was never read widely. But within this book, which is a contemporaneous volume on management of orthopaedic conditions, there are numerous insights into techniques for arthrodesis, tendon transfers, and neurological operations. And the chapter Operationem ad Nerven System is an illustrated chapter with unique nerve transfers that he had described at the time that, if published again today, would receive widespread acclaim. He had these beautiful anatomical diagrams delineating the branching anatomy of muscles and their nerves. So here's the axillary nerve showing the posterior division with innervation to the skin, posterior deltoid and teres minor, and the main anterior division passing forward under the deltoid, supplying the bulk of the anterior two-thirds of the muscle. Even described in this view here on the right-hand side of the slide how the branching anatomy is visualized. Now, he described a nerve transfer to re-innervate the axillary nerve through an anterior approach using fascicles dissected from the posterior cord that would have gone on to supply the long head of triceps. And this is a technique that we use today in reconstruction of patients with tetraplegia to re-innervate the long head of triceps, but we do this technique in reverse, taking fascicles from the axillary nerve into the long head of triceps. He also described how the implantation can be accomplished with a partial section of the recipient nerve and implantation of a donor fascicle. So this is an illustration from his textbook showing the dissection and mobilization of a branch of the posterior cord to the long head of triceps, elevated anteriorly above the latissimus dorsi and teres major, and then inserted into the axillary nerve for re-innervation of deltoid. He also described transfers from triceps into the musculocutaneous nerve for use in upper brachial plexus lesion stop. Now, numerous other techniques that he described include the FCR, the pronated teres, and the palmaris longus median nerve fascicles, which could be transferred into the ulnar nerve for restoration of intrinsic function, something that's become more popular in the last few years. He also described transfers taken from the gluteals, so using inferior gluteal to re-innervate superior gluteal. What was very exciting and now has potential interest in patients with L5 lesions within the spine is transfer of the Soleus branch of the sciatic nerve, which could be transferred directly behind the knee in the popliteal fossa into the deep fascicle to tibialis anterior in the deep peroneal nerve. And this is the branching anatomy of the nerve to Soleus. So Adolf Stoffel really, I believe, is a pioneer of nerve transfer surgery, and he described numerous nerve transfers in his textbook, Orthopaedic Operations, in 1911, published in 1913. And it's only now, with modern times, that we're beginning to rediscover some of these techniques and apply them to our patients. So Adolf Stoffel was a true pioneer of peripheral nerve surgery. He used interruptive nerve stimulation to understand fascicular patterns, muscle innervations. He used selective neurotomy for spasticity and described innovative motor nerve transfers for reconstruction after injury or disease. Those who cannot remember the past are condemned to repeat it. George Santayana.